So we talk something about deafness in children. So in the ear, picture of the ear is shown here. I think we don't have to describe it. So this is the hearing mechanism from the ear, how we see the auditory cortex. So there are neurological issues also. So we can have deafness not only due to ear problem, but in the we actually hear from the brain. So the problems in the hearing pathway also can affect hearing. And then the difference in children is we cannot test their hearing by doing audiograms because we don't get their cooperation. And then we need quiet environment also. So actually hearing loss is not about the ears but about the brain. So actually the brain is hearing, and the hearing mechanism very difficult to understand because we don't have enough data about how we hear at the brain level. Hearing is the first order of event for the development of communication. That means the first in the intrauterine life, first to come is hearing, and in your deathbed, last to go is also hearing. So these are the types of hearing loss in children also. And the non-organic hearing loss we did not talk earlier. Some people, they may be malingering. They don't have any problem, but for their advantage, sometimes they can say, like people who need compensation after accident, they can say they have a hearing loss. So congenital disorders can be genetic or non-genetic. So these are common syndromes which can affect hearing. Otosclerosis, I told you, it expresses in adult life. And even osteogenesis imperfecta. But the other Down's, Marfan, those syndromes, you can identify deafness in children. So these are a few more conditions which can affect hearing. Cystic fibrosis, immotile CTR syndrome is Carter-Gunner syndrome. Cleft palate children, all of them get conductive deafness because even if you repair the cleft palate, eustachian tube is not functioning. So when the eustachian tube is not functioning, middle ear is not functioning well. Then the ossicles cannot vibrate because of the negative middle ear pressure. You should have normal environment, normal atmospheric pressure in the middle ear. So when there is negative pressure, hearing loss occurs. Immune deficiency diseases also can affect. So these are the acquired causes of deafness. I have discussed these conditions. So sensorineural deafness, I told you, genetic ones are inherited, dominant, recessive, or X-linked. Non-genetic ones, they are common to adults as well as children. So perinatal causes, when you give in the neonates, sometimes you use ototoxic drugs for their infections. And maternal conditions also can affect their hearing. In my note, I have mentioned about how to take history and do the examination of a child with delayed speech. So when do we know a child has delayed speech? Is usually at 1 year of age, because parents don't suspect hearing loss, but after 1 year, if the child is not talking, then they take the baby to the doctor. But actually, you can suspect hearing loss from birth. So these are there are things called high-risk babies. Now, in certain countries, we do universal hearing tests in newborn. We also have started it in Anuradhapura, but not all over the country. So prenatal, perinatal, these are the high-risk group. But at least you must check the high-risk children. But ideal condition is to check all the babies who are born, because hearing loss cannot be suspected in children when they are born. So what do? We do diagnose deafness, and then we have to send them to speech and language therapist, because even if we give hearing aids, language development needs some help. And then, so we have given the time period at what they can do at each level. So at birth they cry, and then to babbling at 3 to 4 months, and one word at 1 year, 2 words 2 years, 3 words 3 years, like that. Full language maturation is at school age. So degree of hearing loss, we have mentioned about mild, moderate, severe. We have given the color code here. To 40 mild, 40 to 60 moderate, severe, and profound. So the audiogram levels we have given here. So how do you suspect deafness in a child? Development of speech is delayed, inattentive because they cannot hear, they don't communicate. Hyperactivity also possible, non-responding, poor performance at school. So before you uh, suspect because of non-development of age, each age, if they don't make sounds appropriate to their age, you must suspect. So children with hearing problems, uh, they have hearing differences between sounds in words. So speech and language development, uh, social activities, that will affect the social activities, cognitive and intellectual abilities, because we have 5 sense organs. All 5 sense organs give input to the brain for development. You know, our brain cells are there at birth, but all the connections happen after birth. So within first year you get lot of connections. So it's very important to talk to the baby, even though the baby does not. You cannot say that baby does not hear or baby does not respond. Even if the baby does not respond, you have to continuously talk to the baby. Actually, some mothers don't communicate. They think they sometimes give attention to the elder children, ignoring the baby. So it should not be done from the day one. There should be communication. So these are the tests we do. Audiogram, I was talking to you. Tympanogram again, yesterday I showed you some graphs. BERA is brainstem evoke response audiometry, and this one you don't need patient's cooperation. So hearing technology options. So there are various hearing aids. That these are the very small ones you can insert into the ear canal. These are behind the ear type. Baha is bone anchored hearing aid. Yesterday I showed you a picture about Baha cochlear implant. So this hearing aid, initially when they are born without ear canals, with the band we can fix the hearing bone conduction aid, because children who are born uh, without the ear canal, they need bone conduction aid. Mm. Hearing aids, Baha, we can see which is connected to the bone. So we were talking about hearing aid, and the bone anchored hearing aid is called Baha. It is implanted within the bone. So this is a good option for child without ear canal, or when the patient has continuous discharge from the ear. When they have continuous discharge due to ear disease, you can't fix a hearing aid. Then we can give this type of hearing aid. So benefits of hearing aid fitting. So you can understand your hearing better, and tinnitus also will disappear. Now we have to talk about vertigo. Vertigo, we are going to do a lecture during our skills session also, how to examine a vertigo patient and how to do the history taking. So I am not going to do that presentation, but if you are interested, you can go to my website. That presentation is there in the website. History taking and examination, because examination 20 minutes video is there, cranial nerve examination there, and how to take history also, there's a separate presentation. So it's chandrajayasuriya.net. You can go to my website and then you can go through that presentation and the video. Anyway, before you come to the skills, you have to go through it. So there are conditions in the vestibular system. The vestibular system is divided into peripheral and central vestibular system. The peripheral vestibular syndromes, as a ENT surgeon, I mainly deal with peripheral vestibular syndrome. But neurosurgeons, they can come across central vertigo also. So when a patient comes, patient does not know whether the patient has central or peripheral. So they can come to ENT surgeon or neurologist. So after examination, we have to find out whether it's peripheral syndrome or central one. So how to distinguish between central and peripheral vertigo will be discussed during the examination. It is difficult to do examination in a Zoom lecture. So I will leave it for the skill session. So we talk about peripheral vestibular syndrome. So there are acute peripheral vestibular syndromes like vestibular neuritis, and intermittent ones like benign paroxysmal positional vertigo, Meniere's, vestibular paroxysmia, superior semicircular canal dehiscence, and chronic ones like bilateral vestibulopathy due to destruction of both labyrinths. So when both inner ears are destroyed, it becomes chronic. Acute ones all of a sudden go to the accident and emergency. Intermittent ones, they have in between attacks, but sometimes they are okay. So the benign paroxysmal positional vertigo is the commonest condition affect the vestibular system. All ages can get affected, but especially among elderly. This is due to otoconia. So you can see picture of otoconia here. They are calcium carbonate, and they are free floating in the semicircular canals. So cupulolithiasis and canalolithiasis, two words are mentioned here. Cupulolithiasis is it is attached to the cupula of the semicircular canal. So semicircular canal, there's a sense organ. So when canalolithiasis is, these particles are freely floating inside the ear canal. So how do you know they have BPPV? Because this is the commonest condition affecting the any age group, commonest condition of vertigo. You must know how to diagnose it. So they come with typical history. Rotatory vertigo lasting for seconds, provoked by rapid changes in the head position related to gravity. So when you get up from bed and when you lie down and turn in the bed, and when you go and keep your head on the pillow, and when you try to go to the toilet in between, you get vertigo. And there can be nausea and vomiting. Diagnosis is by Dixolpite test. Again, Dixolpite test we will show you later. So Dixolpite test is a test which has to be done in the bed. So I usually, when I examine a patient with vertigo, I never forget to put the patient to the bed, because first thing I do is Dixolpite test, because a lot of people don't do Dixolpite test. So you miss this condition, and this can be diagnosed and treated very easily by clinical history and examination, because when you do the Dixolpite, patient develops nystagmus. When we see the nystagmus, we can do the correction maneuvers during examination itself, and patient will be very grateful, because usually the oral medication doesn't help in BPPV. Mainly it is the exercises. So what is the differential diagnosis? Other condition which can cause vertigo of short duration, because it's lasting for seconds, only few seconds. So these three conditions I have given. There's vertigo lasting for seconds. So vestibular paroxysmia, it is like condition like epilepsy. So there's an electric current in the vestibular pathway. Patient develop momentary vertigo. And central causes of positional nystagmus, we have to diagnose again by Dixolpite test. So with that will remain for some time, not like BPPV. Superior semicircular canal dehiscence, you know, there are semicircular canals in the inner ear. When the bony covering is lost, small changes in the pressure in the ear canal, sound waves, loud sound, those things can cause vertigo. So this is not a common condition. So even if you don't know much about canal dehiscence, that's okay. But you have to know everything about BPPV. So what is the treatment? No place for drugs. Otolith repositioning maneuvers. These things will be taught in the skills session, Epley's maneuver and Samont maneuver. And we to take extra caution, patient with severe spondylosis, previous surgery, when we do the procedures. And nowadays, we teach them how to do exercises at home also. So brand of exercises also can be taught. Then they do the doctor is doing exercises, the clinician, and then we can ask the patient to do exercises at home. So the Meniere's disease, earlier also I told you, in the eyes, endolymphatic hydrops. So endolymphatic compartment is enlarged. So it's shown in the picture here. This is the endolymphatic compartment in this picture, but here there is hydrops. All the endolymphatic compartment is enlarged. So this is due to excessive production or reduced reabsorption of endolymph. So there should be balance in the endolymph. It is produced and is absorbed. So if there is too much production or less absorption, patient can have eye drops. So migraine patients and BPPV patients are more prone to get Meniere's disease. So migraine is a common condition. Sometimes difficult to distinguish from Meniere's because Meniere's patients have the history is the key to diagnosis. Vertigo lasts for 20 minutes to 12 hours. Unilateral tinnitus, deafness, and fullness. In migraine also, these symptoms can occur. So Meniere's disease, how do we investigate? There is no definite investigation, but we can do a audiogram. PTA is audiogram. There can be deafness in that, and then this is a Christmas tree you can see, and in the cochlea also there is a Christmas tree pattern. This is when we give contrast into the middle ear. So you know it's not easy to give contrast media into the middle ear. So we don't do this test in the clinical setting, but we do audiogram, and then the low frequency hearing loss mimics this condition. So how do we treat? We have to divide the treatment into two groups. One is acute attack, other one is prophylaxis. So acute attack, rehydration with normal saline, antiemetic. When they go read the emergency, if they are dehydrated, we have to rehydrate. We have to give something for vomiting and antivertiginous drugs. Now remember, antivertiginous drugs, sometime when we start, the patient is on that drug for years and years. So it's very important to give antivertiginous drugs less than 1 week. Transtympanic injection, that means we give injection into the middle ear also. We can try that also. But mainly we hydrate and we give antivertiginous drug. Prophylactic treatment is to prevent attack, because if someone has got repeated Meniere's disease attack, they cannot continue their day-to-day life. So we give drug called beta histine, and sometimes we can give injections into the middle ear. And then dietary modifications are important. Salt, low salt diet, and surgery to correct this condition, but it is less common now, surgery, but medication and intratympanic injections are quite popular. Dietary modifications, or how do you say, the 2 gram salt, we ask them to have no added salt. I ask them to cook without salt, but initially they can have food without salt, but after some time, toward the end of the meal, they can add little bit of salt. Then they don't get excess dose of sodium chloride. So vestibular neuritis, you can see in the picture, the superior vestibular nerve is inflamed. The red color is superior vestibular nerve. So they go to the accident and emergency with severe vertigo and vomiting. It's due to a viral infection. So what do we see? Severe rotatory vertigo with movement of surroundings, as nausea, vomiting, and there is no history of tinnitus or deafness. So remember, neuritis, cochlea is normal. So they don't have deafness. No special investigation, diagnosis is clinical. So the differential diagnosis is most important DD is cerebrovascular accident. So when we don't diagnose CVA, posterior fossa, that means in the cerebellum. The CVA happens in the cerebellum. So the posterior fossa of the skull is very limited space. So when the posterior fossa is affected, the hemorrhage or the CVA can affect the intracranial pressure. So it is very important to suspect CVA in emergency, because vestibular neuritis, even if you don't treat the patient is not going to die. But if you don't suspect CVA, so how do you know it's CVA? You have to do the complete neurological examination. So we will again teach you during the skill session how to do the neurological examination in vertigo patient. So treatment is again anti-vertiginous drugs for a very short period. Prednisone 100 milligram daily for 5 days, we can taper off. Rehabilitation therapy. Rehabilitation therapy is important. Why? Why do we have vertigo when we get neuritis? So when we cannot maintain, when we get neuritis, we cannot maintain balance. So when we cannot maintain balance, imagine when we were in the caves, when we were hunters. So if we cannot maintain balance, we will be prey for another animal. So if we have severe vertigo and vomiting, we will not wake up from the our bed. So then our life is protected. That's why the vertigo is there. So we should not suppress it too much. We must let the nature to take over. Nature will take over. Then there can be compensation from the normal labyrinth. So it is very important to give less drugs. Otherwise, compensatory mechanism will be prevented. So the video I have not shown here, head impulse video you can see in my website. So bilateral vestibulopathy. Now we talked about unilateral vestibulopathy, going to the accident and emergency, distinguished from CVA. Here bilateral vestibulopathy is a chronic condition. They don't go to accident and emergency. So what happened? They are both labyrinths are damaged. So it may be idiopathic also, but sometimes it is due to bilateral vestibular damage from ear disease or ototoxicity or bilateral Meniere's disease. Meniere's disease usually affects unilateral one cochlea, but later can get affecting both cochlea. So patients with bilateral Meniere's and ototoxicity and destruction of both labyrinths, they can get this condition. So how do you know the patient has postural imbalance? With the patient has bilateral vestibulopathy, patient has imbalance, oscillopsia during. So bilateral vestibulopathy, you may not find the cause, but you have to treat it. So how do you treat it? Patient can have imbalance. They have severe imbalance, so they cannot do their day-to-day work. And oscillopsia is jumping. There are objects in the visual field jumping. So imagine when you walk, everything is jumping in front of your field. You cannot focus. You may vomit also with rapid head movement. So it's a disabling condition to have both labyrinths gone. No nystagmus. Hearing loss may be present if the labyrinth is affected, otherwise no hearing loss. Some patients may have coexisting ataxia, abnormal smooth pursuant saccades. So these patients have very poor work tolerance because they cannot work because of this oscillopsia. Sometimes they feel comfortable when they have something in their hand. When the farmer has a mammoth in their hand, they can maintain balance. Or when they are sweeping with the eagle broom or the broom, they are more comfortable because there is something to lean to. Right. So investigations. We can do the vestibular testing in the labs, but we don't have proper vestibular labs in the country. But so we suspect bilateral vestibulopathy clinically, and we have to treat. So differential diagnosis, we have given list of conditions. Most of the conditions affecting the inner ear we have given here because some patients only complain of vertigo. So you have to think of other conditions you know about and then exclude them. So rehabilitation therapies, we have to get the use of whatever the vestibular system functions available. This can be done by help of physiotherapists because it's difficult for the doctor to teach all the exercises and it should be custom made also. So we can refer to a rehabilitation therapy. We have one in our clinic, is a physiotherapist, but most of the towns we don't have vestibular rehabilitation therapy. So we have prepared some leaflet for the patient to follow. Lifestyle modifications are important. We have to give a walking stick, good pair of spectacles, and regular exercises can improve the quality of life. So patients should not get homebound because of bilateral vestibular therapy. They should get ask for help and then get socialized so they can have near normal life. Vestibular paroxysmia, this is not a common condition, but I just mentioned here, they don't have any auditory symptoms. They have only vertigo in certain head positions, in certain body position, but it's not related to gravity. They are not gravity related, but they move, sometimes they can get this epilepsy-like condition. So we treat like anti-epileptic drugs. So we do audiogram where there is no hearing loss. MRI will be normal. EEG is also normal. So what do we do? Carbon therapeutic trial of carbamazepine. This has to be given long term because this trial was started recently. So all the patients are still on carbamazepine because we don't know whether we can stop this. So these are semicircular canal dehiscence. I told you there are several semicircular canals in the body, in the inner ear. When the bony covering is missing, like in this picture, where bony covering is missing, when there is a pressure change in the ear canal, they get vertigo. So it is induced by sound or pressure. So clinical features, you can see when you press the ear with your sound also, patient get vertigo, where salva maneuver may increase the vertigo, and they hear their own voice, their own footsteps also. So when they walk, they hear their own footsteps. And pulsatile tinnitus and conductive deafness also they can have. So pressure on the triggers can cause vertigo, and then they can get the vertigo to loud noises, and they develop avoidance behavior. So they, when they have this problem, they avoid movement of the head, they avoid sound. So we have to diagnose and treat them. We can do the audiogram. Usually there can be a conductive hearing loss due to this semicircular dehiscence. Very high resolution CTs can show the loss of bone. So how do you treat? Mild cases, you don't have to do anything. You just inform the patient to avoid the certain condition. Severe, we can do surgery, but you have to remember surgery is also quite mutilating. You have to go to the inner ear and cover this defect. So obliterate the canal. So it has a morbidity. So we have to select patients for morbidity. We do not select patients for surgery unless it's absolutely essential. So I'm going to talk about central vestibular syndrome also a little, because I told you patient does not know whether they have central or peripheral. So when they come, we have to distinguish. These are the common central conditions. That means infarction, hemorrhage. Those things are brainstem CVA, brain CVA, migraine, and degenerative brain disorder like multiple sclerosis. So these patients have attacks lasting to seconds to minutes, like TIA and vestibular migraine. And then hours to days, like vestibular migraine. Permanent syndromes, there are syndromes for downbeat and upbeat nystagmus. These conditions are central causes. Cerebral disorders can be treated medically. So when you examine a patient with vertigo, when you see vertical nystagmus, that's always abnormal, we must refer to neurologist. Nystagmus video again you can see in the website, or we will show you all the videos during skill session. So vestibular migraine. Now vestibular migraine is a common condition. You know, migraine is very, very common. Nowadays, it's getting more common because of the devices, technology, advancement of technology. They get recurrent attacks of vertigo without headache. So female or childbearing age patient present with this condition, they may give in between headache attacks, but during vertigo, they can get this vertigo without headache also. So triggers very important to us. You know, migraine can be diagnosed by triggers. So like reduced sleep, hormone fluctuations, sound, light, smell, motion, food, medication. All these can affect the ear, and then patient can get migrainous vertigo. So vestibular migraine. Typical symptom is vertigo with imbalance, visual disturbance lasting for 5 to 60 minutes, double vision, flashes of light, scotomize, you see a black spot in your visual field, followed by headache, nausea, vomiting. How do you treat? Medical treatment, avoid triggers, dietary modification. So any disease, you know, we talk about treatment, lifestyle modification, medical and surgical. So there is no surgical treatment here, but you can, by lifestyle modification, you can avoid triggers. So certain food can cause migraine. So maintaining a food diary, will help. So the person with severe migraine must maintain a food diary. Then in the food diary, they can mention what they ate and whether they develop uh, vertigo or headache. So it's important to know about the trigger food and other trigger factors. Prophylactic treatment can be given during attack. We can give analgesics, antiemetics. Prophylactic attacks, beta blockers, amitriptyline, topiramate. So these are the criteria for vestibular migraine. These are available in the internet. Probable migraine and definite migraine. You can see the vertigo lasts for vestibular symptom lasts for 5 minutes to 7 to 2 hours. Past history of attacks and the other symptoms are also given. Headache with pulsating quality, photophobia, phonophobia, visual aura. So probable one also symptoms are given. This is a treatment chart. You can see medical therapy and lifestyle modification. And the medical therapy is divided into during attack and prophylactic medication. Lifestyle modifications are divided into two: avoid non-food triggers and food triggers. So functional dizziness, phobic postural vertigo. So the functional dizziness is this patient has a reason for vertigo some time ago, but after even complete recovery from the attack, patient keep on having vertigo. So it's young people. It happens among young people, and they are really scared of falls, and they are anxious. They are scared of large crowds or certain social situations, and because of this they develop avoidance behavior because they are scared of social situations, they are scared of their vertigo, so their personalities also different, so they try to be perfectionist, and when things doesn't happen their way they get depressed. So you can identify these patients by their personality also. So what is the treatment? Treatment is diagnosed by the patient with functional disease are not diagnosed and treated properly, their avoidance behavior can make them homebound. Educate the patient about the illness, desensitize by self-exposure, so we can give the triggers more and more to desensitize, regular exercise, behavioral therapy. Pharmacotherapy also helps, like I told you about the antidepressant, SSRI, selective serotonin reuptake inhibitors. Sertraline, fluoxamine for 6 months with anxiolytic for a short period. So pharmacotherapy is also important because these patients are told they have a different personality trait and they have depression. So post-traumatic vertigo. It's a very common condition. All the patients who face head trauma, they even with or without fractures, they can have inner ear changes. And then the BPPV, the commonest vertigo condition, is also common among after trauma. So BPPV is commonest form of post-traumatic vertigo. So can be unilateral or bilateral, and they are not immediate after trauma. It takes days to weeks. So patient may not remember the trauma also. After surgery, major head and neck surgery also they can get. So repeated maneuvers are necessary. I told you we treat DPPV with correction maneuvers. If we are going to teach you during skills, so these maneuvers sometimes we have to repeat. So childhood vertigo is also not rare. They can get vertigo, but they cannot express or say that they have vertigo. 50% of the cases are caused by one of these three: benign paroxysmal vertigo, not benign paroxysmal positional vertigo, just benign paroxysmal vertigo, migraine, and otitis media with effusion. These are the three common causes. Benign paroxysmal vertigo childhood is a precursor of migraine. So 1 and 2 both migraine. Otitis media with effusion is very common condition affecting children. They take into tube is blocked, they get fluid in the middle ear. So again a common condition we can present with vertigo. So short-lived vertigo, 30 to 60 seconds. And they are scared sometimes. When they get vertigo, they run to their mother and they cry. And they become pale and sweaty. Nystagmus may be present. So we can treat this. Prognosis is also good. Half of these children develop migraine in adolescence. Most have family history of migraine. Vertigo in elderly, like vertigo in deafness in elderly, vertigo in elderly is also a entity. It's multifactorial because maintain balance we need to maintain balance we need vision, proprioception, and inner ear. So in elderly people, all these are gone. In vision, proprioception, inner ear. So bilateral vestibulopathy is also more common among elders. So how do we manage? Check and manage according to the cause. So we have to know the cause. Spectacles, cataract surgery, walking aid, vestibular rehabilitation therapy, and psychological support. Okay, thank you. You will learn more about this testing in during the skills. Please, I invite you to go to through my website to see the examination. Thank you.